today. Um, I am super passionate about, sharing my journey to becoming a surgeon because I know how important mentorship was for me. So I hope I can help provide you with a little bit of that mentorship and if there's anything I can do in the future as you guys progress through your applications to med school and residency, then you can always reach out to me, and I'll put my Instagram account at the end, and you guys can always message me there. So today we're going to be talking a little bit about colorectal surgery. So just as an outline, I'll tell you a little bit about me and my path. Then we'll go through a little guide, what it takes to become a surgeon and what that journey looks like. I'll tell you what colorectal surgery is, and then we'll go through a day in the life of a surgical resident. I know that that seemed like something very intimidating to me when I was before I entered the medical field. So I wanted to show you guys what that looks like. Then we're going to play a little game, general surgery, true or false, and try to figure out what your conceptions or misconceptions of surgeons may be. And then we'll go through some cases. It's Colon Cancer Awareness Month, so I wanted to give you guys a little bit of exposure to colon cancer cases, which is one of the main things we deal with as colorectal surgeons. And then I'll leave you with a little bit of advice if you decide to pursue medical school, and open it up for questions. And I hope to make this interactive, so please feel free to unmute yourself or send a message when we do our little true or false game so that we can hear what you have to say. All right, so my background, currently I'm an affiliated assistant professor at University of Miami Miller School of Medicine, which is where I did my 4 years of medical school, my 7 years of general surgery residency, and now I'm back as a professor, but I am at our regional campus, which is actually located in Palm Beach. I also did a 1-year fellowship at NYU, so I completed that last year. So you want to be a surgeon. What does that look like? So as you guys know, you're in your undergrad years. You have to fulfill your pre-med requirements and of course take the MCAT. Then you move on to medical school where you have to complete your USMLE, which is the licensure exam, all 3 steps of that. And then you match into residencies. So actually this past week, as you may know, was match day. And that's where all the residents from across the country find out what specialty they matched into. And it's a really, exciting day, and I'll tell you a little bit about how that works later. Then you go into general surgery residency if surgery is something you're interested in pursuing. So this involves 5 clinical years, and then there's also 1 to 2 years of research. Most programs now that research is offered, it's either mandatory or it's optional. There's a few programs that are straight clinical tracks, but that's something I'll also go into. And then if you decide to go into colorectal surgery, that's an additional 1-year clinical fellowship plus minus a year of research if you haven't already done research. And other fellowships for surgery can be anywhere from 1 to 3 years. So as you can see, it is a very long commitment. All right, so see something in the chat. Oh, I see. What are the pre-med requirements? So it kind of depends on which medical school you're applying to, but in general, there are things like, chemistry, biology, all of the prerequisites that you need to take in order to, prepare for the MCAT and those things. Another very important component of your application while you're in undergrad is, of course, your extracurriculars, so your volunteer work, your leadership, and your shadowing and exposure to medicine, things like that. Okay, so what is colorectal surgery? So colorectal, like I mentioned, is a subspecialty of general surgery that focuses on the GI tract. And it's actually a bit of misnomer because it's called colon and rectal surgery, but we actually follow, everything from the small bowel, which comes after the stomach, all the way down to the anus. So a huge part of your abdomen that this specialty covers. So conditions that are treated by colorectal surgeons, not sure if you're familiar with any of these, but for example, colorectal and anal cancers, diverticular disease, bowel obstructions, which can be caused by a whole slew of things you see listed there, inflammatory bowel disease, which is Crohn's and ulcerative colitis, then all kinds of anorectal pathologies, and then also functional disorders. So we work with gastroenterologists to manage things like incontinence, constipation, and pain syndromes. All right, so what does a day in the life of a general surgery resident look like? So when you become a resident after your 4 years of med school, you apply to surgery. Your first year is your intern year, and then you'll complete the rest of your clinical year. So in general, this is what the schedule looks like. Obviously, it changes day by day, but you got to expect that you're going to be waking up around 5. This was a huge shock to me when I was an undergrad. I could not have imagined doing that. And then you arrive to the hospital usually about 6 a.m. where you then sign out with the night team. So most programs work on a shift schedule, some work on a 24-hour call schedule, but in general, this is what that looks like. So you sign out and you get report about everything that happened overnight so that you can care for the patients during the day. And that whole process is called pre-rounding, where you look through the chart and figure out all the events that have occurred, what the patient's vital signs have been, the ins and outs, those kind of things. Then you meet with your team to round, which is going, bed to bed to evaluate the patients and make sure that they're doing okay. And then at 7:30, that's when the day really starts. So that's usually what time the operating room cases start. And if you're not going to the operating room that day, then you're doing, clinical work on the floor, taking care of the patients, doing the discharges, taking care of wounds, all those things. That whole process kind of repeats itself before you leave at night. So you round again and make sure all the daily tasks have been done, that the patients are doing okay. Then you sign out to the night team so that they can take over where you left off. Now, after that, you still have to do all the other things, normal people do: work out, eat, sleep, study. So that all happens in the, overnight until you come back the next day. So it is pretty grueling. As you can see, it's a lot of hours, but definitely worth it. Now, throughout all of that, you also have, as you can see on the right side, other educational requirements that are a component of your residency. So this is a huge focus, things like tumor board, morbidity and mortality conference, grand rounds. You, of course, have vacation. And then the research years, like I mentioned, are usually some places mandatory, some places optional, 1 to 2 years of that. And then after all that, you'll apply again and go through the match for your fellowship of choice. Anyone have any questions about that? All right, keep going. All right, so we're going to play a little game, and I want to see your comments in the chat. So open up your chats. So I had a lot of misconceptions before I entered medical school, and even in the beginning of medical school, about what it meant to be a surgeon. So I want to see what you guys thought. So the first one I thought is that you have to be mean to go into surgery, and that everyone else is mean around you too. Anyone think that's true or false? Oh, good. You guys think false. All right, perfect. So yeah, it's actually false. It does have that misconception, the field of surgery. People think it maybe is an aggressive field, that certain kinds of personalities won't do well in surgery because of that, but I definitely think that is false. Okay, next question. You will have no life as a general surgery resident or as an attending. Anyone have any thoughts about that? Someone said true. Okay, a few people said true. Again, it sort of depends what you go into and where you work, but having an extracurricular life outside of surgery is totally possible if that's a priority for you. So that's false. I'll give you some examples. So this is a picture of my wedding. I got married when I was in my 3rd year of residency, or my first clinical year. And the other 4 people in that picture are actually my co-residents. So all of the other residents of my program from my year. So we all got the same day off to, celebrate this moment. So that was, I like to show that example of all of us being together and enjoying that. And then this next picture, it shows the 2 kids that I also had while I was a residency, which probably would not have happened many, about 10, 20 years ago. That was more rare. But now having a family is encouraged, and especially if you have to take time during the research year, sometimes it's a little bit easier to do that. So Sydney, the older girl here, was born during my 2nd year of research, and then Ella was born in my 7th year of residency, or my 5th year of clinical training. All right, yes, they are cute. Okay, so next question. Residency is brutal and no fun. Anyone have any thoughts about that? All right, got some mixed reviews, some true, some false. So, I guess it depends on what your experience is. Obviously, everyone's experience is different, but for me, that was false. This is us intern year, so me and my fellow interns, and yes, we are all passed out in the middle of the day because it is hard and grueling, like we mentioned, but also a lot of fun. So when you get to do big rewarding cases, this was an example of my first big vascular case that I did as an intern. It was an emergency. It was very exciting, and the patient did well. So, moments like being exhausted on the left make up for the ones on the right. So it is intense, but I wouldn't call it no fun. All right, so here's a good one. You should choose surgery if you can't imagine yourself doing anything else. So people told me this a lot. Anyone have any thoughts about that? People would say, don't go into surgery unless that's the only thing you can ever picture yourself doing. So that one I actually think is true. Surgery, it never stops. You're always worried about your patients. A lot of times you're on call thinking about them, or, trying to work your schedule around being available to take care of someone who's sick. And it is a more acute field than, something like primary care. So, you do have to believe in that, lifestyle and that mentality that this is going to be a priority, because that's the only, fair way to take care of these patients in the way they deserve. So yes, you shouldn't go into this field unless it's really the only thing you can imagine yourself doing. All right, the last one, surgeons do and don't think. This is something I heard a lot, even all through medical school. The medical type doctors, the internal medicine doctors, and those subspecialists would say, you just operate, you just cut, you don't really think. And this is something that's definitely false. And I'm going to show you that with a few case examples about how much work goes into the planning of the operation. In fact, the actual operating, the technical skill of surgery, you may think is the thing that takes a lot of time to learn. And although it does, and you obviously improve at that over the course of your career, that's actually not really the hard part, in my opinion. The hard part is learning when not to operate, or when to, what to do to make sure your patients have the best outcome after your surgery. All right, so how do surgeons work up patients? So patients with colorectal diagnosis can present to clinic in an elective fashion or in a more emergent setting, like in the emergency room. We often see consults in the emergency room. So how do we work those up? I'm going to show you in general, step-by-step process to do that. And the workup is always the same. And this holds true for any specialty. So I'm sure if you've seen other cases presented, they've probably gone through a similar algorithm. But basically, you take your history and physical. It's where you gather all your information and examine the patient. And then you need some objective data. So that includes labs and imaging. And then you have to do that medical management part that I spoke about earlier. So you have to figure out, what do I need to do to stabilize this patient, and how can I optimize them for surgery? Then you do the actual surgical management and the post-op care, and then you follow and surveil them over time. And that's another thing I like about colorectal surgery, is it's different than, for example, acute care surgery, where you may take out someone's gallbladder and that's done after you see them on their post-op visit. Most of these patients have either cancers or a chronic condition that you're following them over time. So you get to have that long-term relationship that's sort of rare in other surgical specialties. All right, so we're going to go through the first case, and I understand that this is obviously way over your head. I don't want to, scare you guys or intimidate you. I know you don't have any medical knowledge yet, but I want to show you just sort of the, complexity and the nuances that it involves when we work up patients. And I think you guys will be able to get a little, I'll ask you some questions, and I want to hear what you think about this. So let's say you have a 66-year-old woman who comes to your office with rectal bleeding. So she reports that this started about 6 months ago, and it's been worsening. She's had no pain, but she's had a 10-pound weight loss over the past 3 months. So what do you do first? Like I mentioned, we have to take our detailed history. So what are some questions you think would be important to know about a patient like this, coming to your office with a new complaint, rectal bleeding, and weight loss? Yeah, exactly. I love that. How long? What diet are they taking? So those are all excellent questions. So in general, when we take a history, we use a lot of mnemonics in medicine, because especially in surgery, we're not that smart. We have to, have help remembering things. So these are some mnemonics that I wanted to give you, so you could get an idea of how, how to keep track of everything you have to ask. So sample history is one that we call it. So we ask about the symptoms, everything related to, what the patient is experiencing, pain or bleeding, for example. What allergies do they have? Because that will guide our treatment. If they're on any medications that could be causing this or interfere with something we plan to do, any important past history, what was the last oral intake and when was that, and then any events that led up to this particular episode of pain or bleeding, whatever the patient's there for. And then on the right, you see another mnemonic. So this is a mnemonic we use to better characterize the pain. So things like onset, when did it start? Location, where is it? Duration, how long has it been going on? Characterization, so for example, is it sharp, stabbing, throbbing, different qualities of the pain? Are there any alleviating or aggravating factors? Does it radiate anywhere, meaning does it spread to other parts of the body? And what's the temporal pattern? Does it get worse throughout the day? Does it wake them up at night? Is it worse after eating? All those kind of things. And then the severity. So usually for severity, we use a scale of 1 to 10. So as you can see, just this portion of the history taking of the patient is going to give you a lot of information to figure out what's going on. So let's say the patient tells you, you ask all that history, they tell you they're having blood with every bowel movement, and they've also noticed their stool is thinner, and they feel like they can't get everything out. So they have no meds, no allergies, they haven't seen a doctor in years, never had a colonoscopy or other surgery. And then we do a review of systems, which means we ask them head to toe, if they're having any other symptoms anywhere else, and the patient reports to you weakness, fatigue, and weight loss. And they also tell you that the father and grandfather died of a type of cancer, but they're not sure which one. Now you've gotten a lot of information for them for their history. The next step is to examine the patient and see if you find anything abnormal. And the very first part of that exam is always the vital signs. So you guys are all familiar with these probably from when you've gone to the doctor yourself. And the vital signs are called vital signs because they're vital. They're super important. So we want to know things like the temperature. Oh, hold on, I have a visitor. Sorry, my daughter just popped in, but okay, so we want to know the vital signs. So we take the temperature, the heart rate, respiratory rate, and blood pressure, and the ones that I give you here are actually normal. So that tells us about the stability of the patient. And then we want to do an exam. So we always do a full exam, but in surgery, we're really concerned about the belly exam, right? We want to know what's going on in the belly, where the pain is or where the bleeding is. So we look at this patient's belly and we see that they're distended or bloated, but they're soft. They're not having like a rigid, hard abdomen, which would be a bad sign. We don't see any surgical scars. So that goes along with what the patient was saying, no previous surgeries. And we don't feel any masses, but when we do a rectal exam, we see blood. And I see someone saying they want to get an x-ray. Okay, so first we want to determine, is our patient stable or unstable? That's always the first question we ask ourselves, because if the patient is unstable, then we're going to have to do a whole lot of other things first before we waste time with this workup. So would you guys say this patient is stable or unstable? Stable, perfect. Yeah, so I gave you the vital signs. The patient's in discomfort, but they're not dying right in front of your eyes. So that's good. So patient's stable. So we have time to do all these things, like you mentioned, get x-rays. So what's on our differential? A differential is a list of diagnoses that we think this could potentially be. So can anyone think of anything they think about what's going on? Patient with weight loss, some bleeding coming out when they poop, changes in what their stool looks like. Any thoughts? Infection, okay, could be cancer, could definitely be. Great. Okay, so yeah, we need some objective data. So in this particular case, we see a problem with the gut, right? And there's blood coming out in the poop. So what do you think the easiest way to evaluate the colon is? In this particular case would be a colonoscopy. So does anyone know what a colonoscopy is? Can you describe how that works? I have a little picture here. Okay, you guys have heard about that. So basically it involves a camera that's on a long tube here that we pass up the butt inside the colon, and we actually can look at the entire colon from the inside out. It's pretty awesome. We can take pictures, we can do biopsies, we can figure out what's going on and is there a mass. So in this particular patient, this is what you see when you put in the scope. So you see some normal tissue here, and then you see a big mass, right? This doesn't look normal, and it even looks like it's bleeding. So that could totally explain the blood coming down, right? So this is why colonoscopy is so important. And I had mentioned this patient was 66 and never got a colonoscopy. Does anyone know what age you should get a colonoscopy just for routine screening? Okay, someone said 60, someone said 50, lots of 50s. Okay, so it actually has recently changed to 45. So the new recommendation is age 45. And that's because over the last 10 years, we have seen so many new cancers in younger patients. So it's really important. And I hope, you guys in Colon Cancer Awareness Month will help me encourage people in your family, friends, anyone over the age of 45 to get a colonoscopy. It is, actually a life-saving intervention. And someone asked, do you get anesthetized? Yes, you're put to sleep for this. So you're under sedation. You don't feel any pain. It takes less than an hour, and we can get a lot of information. So for average risk people, we do this at age 45. If you have a strong family history of colon cancer or other conditions, then that age actually lowers. So very important to get screened. All right, so here's a little anatomy picture just so you have an idea of what I'm talking about. But you guys have probably heard of the appendix. So the appendix is at the edge of the cecum. This part is called the ascending colon, the transverse because it goes across transversely, the descending, the sigmoid because it looks like an S, and then the rectum, and then out the anus. So this is sort of what your colon looks like. And this little thing sticking out is it's cut here, but your small bowel leads to the colon. So you eat the food, goes to your stomach, goes through your small bowel where all the nutrients get absorbed, and then it goes into the colon and comes out as solid stool once the water is absorbed. Any questions about that so far? All right, so during our colonoscopy, you can see this tube Oh, how often should you get screened after 45? Someone asked. Okay, so that's a very good question. So if you have normal findings on your colonoscopy, you actually only need one every 10 years. So that's pretty good. You don't have to follow up for 10 years because colon cancers usually start as polyps, and that whole process from going from a polyp to a cancer usually takes about 10 years. So that's sort of the justification for that. That's if you have no symptoms. However, if you have if a finding of a polyp or other certain family history conditions, that interval every 10 years may actually be decreased every 5 years or even less. So it's very important to, it's an individual basis, and your GI or colorectal surgeon will tell you when to repeat that. So one great thing about colonoscopy is we can also do interventions through it. So here you see the scope, and you see this little kind of jaw-like thing coming through the scope, and we use that to take biopsies or little bites out of these masses or polyps, whatever we see, and we can send those to pathology to figure out what's going on. So in this particular case, we took a biopsy of that big yucky bleeding mass that you saw, and it came back as what's called moderately differentiated adenocarcinoma, which basically means colon cancer. One other thing we can do with colonoscopies, which are either performed again by a gastroenterologist or a colorectal surgeon, is we inject some dye. This is actually called doing a tattoo, just like a tattoo on the skin. We inject some dye under the mucosa. And what's really cool about that is when we're in the operating room, that dye, we can see through the bowel wall, and we can tell us exactly where the cancer is to make sure we're taking out the right part of the colon. Does that make sense? Okay. So let's say you do all that, you get your biopsy, it tells you it's cancer. The next thing we have to do is stage the cancer. So you guys probably have heard about the stage, and the stage refers to a few different things, but one of them is if the cancer has spread. So if the cancer is found in other parts of the body, for example, you see metastases or spread of the cancer in the liver, that would be considered, metastatic cancer, stage 4 cancer. So we have to determine, is the cancer localized or is it metastatic? So that's the next step, and we do that with imaging. Now, every time we work up a patient, regardless of if it's a cancer patient or some other problem, we have to ask ourselves two questions as surgeons. The first question is it resectable? Meaning, can we take out this problem or this cancer? If the cancer is invading all kinds of other organs or different situations, it may not even be able to be removed at that time. So that's the first question. Can we even take it out? Is it resectable? The second question is we have to consider all these patient-specific considerations. So this goes back to the part about surgeons thinking and not just doing, right? We can all do the technical task of taking out the cancer, but should it be done? And how should it be done are important questions too. So for example, does this patient smoke, or are they malnourished? Because that will affect the way we do the surgery. Is it an emergency? Are they stable or not? That also affects it. Is the bowel dilated? So if the patient has a bowel obstruction because the cancer got so big that it's blocking up the lumen of the bowel, then that also changes which surgery we do and how we do it. And then of course, what does the patient want? Do they even want surgery? Do they want something less invasive? So all of these things are super important. All right, so here are some diagrams just to give you an idea of what part of the colon we take out, depending on where the cancer is located. And the reason we do it this way is because we have to take the blood supply and the lymph nodes that go to that region of the colon to help decrease the risk that the cancer will spread or become metastatic. So in this particular case that I presented, the patient's cancer was in the sigmoid, so that's a bottom left block here, and you can see that we would take out this portion of the bowel and then reconnect the rectum to the descending colon. So like I mentioned, the blood supply is what's important. So this blood supply, called the inferior mesenteric artery, comes off the aorta, which is a major blood vessel in the body, and we have to take that there so we can get all the little lymph nodes that travel along here. And then we want to leave the healthy edges of the bowel that still have blood supply so we can connect them again. So have you guys heard of robotic surgery? No, okay. So one thing I really like about the field of colorectal surgery, we have a few yeses, is that we often do our elective procedures or non-emergent procedures with the use of the robot. And the reason this is a lot of times we're operating in narrow little areas, and the robot helps us be more precise. So this is just a diagram so you can get an idea if you've never heard of this or seen this, but the surgeons sit at these consoles or these machines here where you look inside and you can see what's going on inside the belly, and you operate with your hands these instruments that are over here at the patient's bedside. So you may be 10 feet away from the patient for the majority of the surgery, operating these instruments here. So here's another diagram. The surgeon's here sitting at a console, the patient's laying on the bed with the instruments inside and a nurse or assistant at the bedside. And then you can see what those instruments look like. So they're actually very small, similar to laparoscopic surgery. Okay, someone says, do perform some robotic surgeries a while ago. Okay, cool. So again, this is what our patient looked like with the robot instruments inside the patient, and we are aiming to take out this portion of the colon, the sigmoid colon, where our big cancer is, okay? So now you may ask, if you think about the colon like a pipe, right? We have this big pipe and we have to take out the tumor. Now we have to reconnect those edges of the pipe, right? So how are we going to do that? There's a few different ways we can do that, but one way we use is when we're working in this part of the bowel is called the circular stapler. So as you can see, the stapler has this one piece here that actually goes through the butt, through the anus, and this other little part of the staple goes through the more proximal colon, the healthy part that we have left. And then you close these things together and you make this new connection. So now you've closed, you've cut out that bed area, closed your pipe together and made a new connection between the healthy edges of the bowel. And that's called an anastomosis. Now, there's some really cool technology we use in colorectal surgery that I wanted to share with you, just so you can see how amazing and advanced this field is and how much things change. So one cool thing we can use is something called ICG fluorescence. So this allows us to do two things in colorectal surgery. One is look at the bowel perfusion. So remember I said we're taking the blood supply to the colon. So we have to make sure that the new healthy bowel we connect is perfused or supplied with blood. So we inject it IV and the colon will light up the part that is still healthy. And then you see this other part is not lighting up with green. So if that's the case, we know we have to cut the bowel here because this part has died. It is no longer receiving blood supply because we took the blood supply with our cancer specimen. So that's really a cool technology. Another thing we can do is the ureters, which are the tubes that travel between the kidney and the bladder carrying the urine, are often in the region that we're working here. And we can inject this dye through the ureters so that they light up like a Christmas tree and we can find them more easily when we're doing this surgery. So for example, if you look at picture A, you don't really see the ureter unless you're really, really looking for it. It's kind of hard to find, right? But in picture B, you see it light up. So it helps us find the ureter and protect it and make sure that we don't injure it. So lots of cool different little tricks we can use in this field. All right, so now you're going to get a pathology report after you send your specimen to the pathologist. It's going to include all kinds of information, but the important one for you to know is this bottom part where it says staging. So this cancer is staged as T3, which means the depth of the tumor, regional lymph nodes N1, meaning some of the lymph nodes were involved, but distant Mets, it didn't tell us because this is just what the pathologist is seeing. They don't know if there's other Mets, but we already worked up our patient with a CAT scan, so we know there was no spread anywhere else. All right, so then we use that information to get our stage. So we said our patient, I think we said it was T3N0, right? So that's a stage 2A, which you can see here. So we correspond that to this chart, we figure out our stage, and that's important because it tells us about survival. So if we look at this next chart, if your patient is 2A, that 5-year survival rate is almost 90%. That's awesome, right? That's the cool thing about colorectal surgery is even though the cancer was pretty deep and they didn't have lymph nodes involved. So our patient has a very good survival with the treatment that we've given them. And that's one thing I love about this field. So after you get the results of your pathology, we'll send this patient to talk to the oncologist to determine based on the tumor characteristics if they need any further treatment, chemo. All right. So we use what's called a multidisciplinary tumor board, which is a conference of specialists from medical oncology, radiation oncology, radiology, pathology, social work, nutritionists. Everybody gets together all in the room and discusses each patient case by case so we can evaluate the tumor characteristics in the context of this patient and how healthy they are overall, what their desires are, and figure out if they would benefit from chemotherapy to help the cancers from spreading to other parts of the body. All right, and then this is I don't want to get into the nitty-gritty of this, but this is something I wanted to show you, NCCN, or National Comprehensive Cancer Network. These are guidelines that will be very helpful to you when you go into residency because it goes through every cancer and what the treatment recommendations are and their surveillance are. So depending on the stage of the cancer, we have to follow up our patient, for example, every 3 to 6 months for 2 years, and then every 6 months for 5 years with different imaging to make sure that the cancer hasn't returned. So that goes back to another thing I love about colorectal, which is this longitudinal relationship with the patient. All right, so real fast, I want to show you, let's say a similar situation, but the patient presented a little differently. So the first question we had asked ourselves before is, was the patient stable or unstable? So now let's say a similar patient, but they come to the ED vomiting with abdominal pain. They tell you the same thing, they lost weight, and now their heart rate is 122. And they're sick, they look more sick, their belly is distended, it's firm. So now the situation is a little bit different. So you get an x-ray, which is something someone wanted to do before, and here you see the colon. This is not normal. This colon is super big. We call it distended or dilated. So now we're getting a little bit concerned. So we do a CAT scan in this patient, and we see this thickening here, and you can see that also down here in the sigmoid colon, this thickening. So this is concerning. We don't always see cancers, on CTs because they're they're within the lumen of the bowel. But in this particular case, it's caused so much thickening of the bowel wall that we can actually see it. And because it's causing basically an obstruction, the bowel more proximal or in front of that is dilated and getting big. And that is what is making this patient sick and unstable. So in this particular situation, we now have what's called a large bowel obstruction. And right now we don't know what it's caused from. It could be cancer, it could be a stricture, diverticulitis, different things. But this is an example of what it would look like if we opened up this patient, we took him to the operating room, and you see a huge, big dilated bowel pop right out. I wanted to show you this picture because although I mentioned in the first case, we did this whole nice workup, we did a lovely planned operation with robotic surgery. That's not always the case, because if the patient is sick with dilated bowel, sometimes we have to do a big midline open laparotomy incision to be able to get that bowel out. And in certain cases, in surgery, we may not be able to reconnect the bowel back together, like I showed you with that stapler. So has anyone heard of an ostomy? Okay, some people have heard of an ostomy. So an ostomy is when the colon comes up to the bowel wall. So here you see, again, you're ascending, transverse, descending. But now instead of connecting this bowel to the rectum, we're bringing it up to the abdominal wall like this, and this will go into a bag. That's called an ostomy bag. And the stool will be temporarily diverted into that bag until it is safe to make that new connection. So in this particular patient, they were unstable. They had a bowel obstruction. Their bowel was very dilated and sick. So it would not be safe to make a new connection. So we have to temporarily use this diversion. So this is what an ostomy would look like. Okay, so I just want to show you a picture of what the specimen might look like if you were to open up what we took. So here you see the colon, the cancer is somewhere around here. Here we took all this blood supply and lymph nodes. So this part's called the mesentery. That's where the blood supply and the lymph nodes live. And if we sliced open the bowel, you would see that yucky fungating cancer mass in there. All right, so I know that was a lot of information. I probably scared you all away, but did I convince you to go into colorectal surgery? I hope I've showed you that this is an incredibly cool field, diverse. We take care of a lot of pathology, patients from old to young, really sick, others with acute problems, and that longitudinal relationship where we follow our cancer patients over time is super rewarding, and I think it's an incredible field. So yeah, colorectal has it all. All right, so here are a few more pictures. So this is me with a resident doing a robotic case. So usually the robot, you have two consoles, so you can teach or another person can help you. This is us doing another procedure, open, and here you can see same thing, open surgery. So again, a lot of variety. All right, so I wanted to leave you with a little bit of advice. I think we have a few more minutes, but so for those of you who think you may go into med school, it is overwhelming. I get that. It's intimidating and it's can really just be terrifying. But I also want you to know that it is exciting, inspiring, and a huge privilege. And you really deserve to be there. And you have to believe in yourself and believe that you can do well and achieve all your goals. And you really do have everything you need to succeed. So here's some advice that people gave me that I wanted to leave with you that really helped. So a few rules. Rule number one, you have to pay attention to everything. So as you see, you're going to go through college, and you're going to go through med school, and you're going to encounter certain, basic science subjects that you really have no interest in, or they're going to make you rotate in a specialty that you want nothing to do with, like maybe psychology, neurology, something totally different than what you want to do. But you have to pay attention because you only have a limited amount of time there. And it is so important to absorb as much as you can and make every moment count so that you can help your patient, because, medicine is really a multidisciplinary field and you really need to know about everything. So rule number two, like I alluded to at the beginning, is you need to find mentors. So a mentor doesn't actually have to be, a formal assigned person. You can find different people that you want to emulate in different aspects of your life and career. You don't want to waste time recreating the wheel. You want to see what has worked for people who are successful, and how you can make that work for you. And mentorship has been so incredibly important to me, and especially in my career now. The person who is currently my partner was one of my teachers when I was a resident that I met actually when I was a med student, 12 years ago. So, every encounter you have with someone who inspires you, you have to continue to nurture that relationship and that mentorship. So rule number 3 is work a little harder than everyone else, but don't be competitive. The only person you're allowed to be competitive with is yourself, because it really doesn't matter how well or how poorly anybody else is doing. Another important thing is don't expect to be recognized for your hard work. It took me a really long time to kind of accept that. We all want that positive reinforcement and people to, high five us and toot our horns and all those things. But if you're constantly waiting for that validation from somebody else, you may never get it, and it's going to be very frustrating for you. So just, try to be better than you were the day before. Another thing I wanted to point out is the importance of being flexible. So a good example I give is if you're, using a particular study strategy, for example, and it's not working. Let's say you take the MCAT and you fail. You need to adjust, and you're allowed to change the way you do things, and you can adapt. That's how we function as humans. So, try different things, see what works with you, and just be flexible and adaptable as you go through your career. And finally, rule number 5 is keep your eye on the prize. So don't think of med school residency as something you just have to get through. Like I showed you at the beginning, you're living the prime of your life, your 20s and your 30s during that time. So you want to enjoy that time, do all the things that make you happy, if that means having a family or traveling or whatever it is. Just keep your eye on the prize, that the end game is worth it, even though it may be stressful on that day to day. All right, so I am on Instagram at Juliet Ray MD. If you want to follow me there, I have a lot of fun facts this month about colorectal cancer. You can share with your family and your friends. Now you guys all know the screening age is 45, so you guys can help me spread the word this month for Awareness Month. And you can also reach out to me on the messenger there if you have any questions. All right, thank you guys. Any last minute questions? You can post those in the chat too.
Okay, I think we're all set. Well, thank you, Dr. Ray, for coming today. Thank you for making time for presenting this to us. It was a very insightful and very interactive experience for all of us. And all of us really did participate. And that's something that I personally loved about this. Everyone here, please make sure you complete the quiz link. If you get a 2 out of 3 on the quiz, you'll be receiving a 1 hour of shadowing, virtual shadowing. So please make sure you complete that. And thank you again for attending, and thank you again, Dr. Ray, for making time to meet with us.